Hi, my name is Melissa Dennis. Today I will be presenting a study that examines whether vaccines challenge responses truly help clinicians determine which patient with hypogammaglobulinemia or suspected CVID require immunoglobulin replacement therapy. For many decades, vaccines responses, especially for pneumococcal polysaccharide vaccines, have been center of diagnosis criteria for CVIT. But because our understanding of CVIT biology and genetics may evolve, there is an increased debate about whether this test remain meaningful. This study directly addresses that controversy by evaluating vaccine responses in two large patient cohorts in New Zealand and analyzing whether these responses actually differentiate patients who eventually need immunoglobulin therapy from those who did not. The primary goal of this study was to determine the clinical utility of vaccines challenge responses in the evaluation and management of those with hypogammaglobulinemia, particularly with those being assessed with CVID. In other words, can we rely on vaccine responses such as tetanus or pneumococcal polysaccharide vaccines to decide whether a patient truly needs long-term IVIG therapy? Well, the authors wanted to let us know whether vaccine responses actually correlate the disease severity or clinically outcomes. This is important because some diagnosis guidelines still require impaired vaccine responses to diagnose CVIT, even if the patient has clear symptoms and very low immunoglobulins. Given newer conjugate vaccines and growing use of genetic testing, the study aimed to test the relevance of traditional vaccines challenges methods in modern immunology practices. Now, let's go over how the authors approach the goal of the study. Well, to answer this question, the authors used two national New Zealand cohorts that provided real-world longitudinal data. In first place, the New Zealand hypogammaglobulinemia study, and in second place, the New Zealand CVIT study. Let's go over the New Zealand hypogammaglobulinemia study. Well, this study basically review the study of adults who were not receiving this therapy, followed for more than 12 years, allowing to identify patients who remain stable versus who eventually require treatment. In the New Zealand CVID study, where adults receiving IVIG or S, S, SCIG for CVID were linked to national healthcare records, allowing the tracking of hospitalizations, morbidity, and mortality. These cohorts gave the authors a unique ability to compare individuals treated with high immunoglobulin who had more severe clinical disease versus individuals monitored without treatment. Vaccine responses measure uh, showed that the authors analyzed the responses to tetanus toxoid, diphtheria toxoid, Haemophilus influenzae type B conjugate vaccine, and pneumococcal polysaccharide vaccine. They examine the authors examine whether any of these responses differentiate significantly between the treated group with those who eventually require IVIG and the untreated group who were monitored safely without therapy. They also made sure that immunoglobulin levels, switch memory B cells, hospitalization, and development of bronchiectasis and mortality were also measured. Now, let's go over the major results of the study. The most striking finding was that vaccine responses did not distinguish treated from untreated patients. Immunoglobulin levels and clinical outcomes have to be reviewed. As expected, treated patients had significantly lower IgG, IgA, and IgM levels. Treated patients showed a higher hospitalization risk and had a much higher risk of bronchiectasis. On the other side, unmonitored but untreated patients remain generally stable. These findings confirm that the treated group had more severe disease. However, the vaccine responses told a different story. Protein vaccine responses, surprisingly for most patients in both groups, had adequate protective responses, even those with clear clinical symptoms on CVID, which require immunoglobulin therapy. Nearly all patients, including those with severe hypogammaglobulinemia, had protective tetanus and HIV antibodies. Diphtheria responses were monitored but still overlapped significantly between the two groups. Now let's go over pneumococcal polysaccharide vaccine responses. This was the most important part of the study. There was no significant difference between treated and untreated groups and their ability to maintain pneumococcal polysaccharide responses. This means that patients with severe CVID requiring immunoglobulin therapy may still show normal pneumococcal vaccine responses, possibly due to immune memory from early vaccination before the disease progressed. Why is this important? Well, it's important because many diagnosis guidelines currently rely on pneumococcal vaccine responses to decide whether a patient should get immunoglobulin replacement therapy. This study shows that reliance may be misplaced. Now, let's go over the outcome of the study and the future research impact. Well, basically, the outcome is that clinical relevance of vaccine responses is limited. The key takeaway is that vaccines challenge responses, specifically pneumococcal polysaccharide responses, are poor tools for distinguishing which patient need immunoglobulin therapy. Many patients with clinical significant CVID and severe hypogammaglobulinemia still demonstrated normal vaccine responses. which could mislead clinicians. Um, Basically, the impact on diagnosis criteria is that this study supports a shift in diagnosis. Um, because they created emphasis on clinical representation due to current infections, organ damage, such as bronchiectasis, and chronic lung disease. Also, there is a greater reliance on objective biomarkers because consistently there is a low IgG levels, and there was reduced switch memory B cell. There's an increased use on genetic testing due to genetic diagnosis that eliminates the need of vaccine testing. And there is a reduced reliance on vaccine challenges. For future research impact, there is a study will highlight several criteria for future investigations, like development of better biomarkers for CVID, the genotype and phenotype studies, because it understands which predicts severe disease, and also the prevention of diagnosis frameworks for future guidelines that may eliminate vaccines responses requirements. And also there is a longitudinal immune monitoring to predict who will progress from mild hypogammaglobulinemia to true CVID. In other words, the overall of the study is that argues strongly that vaccine challenges should not be used to deny immunoglobulin replacement therapy in symptomatic patients, which clearly um, reduce IgG. This is the end of the video. If you have any questions, you can leave it in the comments, and I will see the discussion post. If you have any questions, you can also post it over there.